ripretinib works by a very different mechanism than the other tyrosine kinases that we are used to using. Those drugs essentially work to inhibit the phosphorylation of the kinase. If you remember from your, I guess, molecular biology or biochemistry, kinases function by being activated by ATP. And imatinib and Sutent and regorafenib are really working to inhibit that process so that the kinase can no longer do its work because it doesn't have the energy to be activated. In reality, when that activation process occurs, there is actually a conformational change of the protein. There is an activation loop that moves from an inactive conformation into an active conformation. And ripretinib essentially prevents that process from occurring and holds the molecule in a state that is inactive and can't change. So it works very differently. And I think one of the things that's exciting about that is that when Sutent and regorafenib were designed and imatinib discovered, the way that they worked was somewhat dependent on the type of mutation that the kinase had. Some mutations were not, would not allow for the binding of the drug. And ripretinib seems not to have that issue and may therefore be effective across more different types of mutations. And I think that the activity that was seen in terms of controlling disease suggests that it can work across many different types of mutations because patients who are in fourth line or beyond tend to have a disease that is now not only has the initial diagnosing mutation that they were found to have at the time of their initial presentation, but multiple secondary mutations that are associated with resistance to the other medications. Ripretinib likely has mechanisms of resistance as well. I don't think that we fully understand what they are yet, but that's going to be something to understand so that we can think about how do we continue to treat patients as we move forward. As always, when there are side effects with medications, it's important to manage them. With these drugs, while we now have 4, maybe 5 drugs for these patients, we want to have patients have the benefit of them for as long as possible. So with the toxicities that I mentioned, with anemia, I think it's always important to double check, are we sure that there is no loss of iron, B12 or folate deficiency to help patients? Helping patients understand how to manage fatigue is also important. And then just monitoring blood counts to make sure at some point patients don't require having blood or transfusions. Typically that's not something that we see, but it's certainly important to monitor. Monitoring blood counts, you certainly don't want to put a patient at increased risk with a low white blood cell count. Not something that we saw that was a significant issue. Kidney function abnormalities. Probably with ripretinib, not a major problem. There is a study that is specifically evaluating how ripretinib is tolerated and what types of pharmacokinetics the drug has even in the setting of renal insufficiency. With hand-foot syndrome, very similar to what we've done with other drugs. It's important to make sure patients use good emollient moisturizing lotions. We tend to recommend udder cream if somebody has particularly bad hand-foot syndrome. Udder cream with urea is helpful. Some people will find that a steroid cream can be helpful in terms of symptoms. I typically will tell patients before they start taking drugs with hand-foot syndrome that they want to make sure that if they have any calluses, that they try and minimize those as much as possible. That it's important to wear shoes that and socks that limit friction while they're walking. So want to avoid shoes that are very tight. Uh, Many of those things are very helpful. One side effect with ripretinib that can be seen with other agents as well is muscle cramps. And I think for some patients that is something that is particularly annoying because it can impact what they want to do on a daily basis because of discomfort or sometimes even just muscle spasms where they are cramped up and they sort of have to unbend their fingers, for example. The why people get that is not 100% clear, but some of the ways that I've suggested patients work with this is, one, to make sure that they can continue to be well hydrated. We think that some of this may be associated with low electrolytes, with things like magnesium, calcium, phosphorus, potassium. And so certainly those are things that I check when patients are on these drugs to make sure that they're not running low, and particularly if they're having symptoms to make sure that they're getting supplemented, and that may be helpful. Some patients find stretching, use of some topical creams can be helpful as well. For the hair, there's not much you can do about it. It happens. And so depending on your patient, most of them I have not found have required or asked for something like a cranial prosthesis, but it's certainly something to be cognizant of and make your patients aware of. Certainly, if anybody is reporting any changes in the skin, it is important for them to make sure that they're seen by their dermatologist to make sure there is not a lesion that should be addressed by removal.